So today we'll learn steroid in herpes simplex keratitis, why, when to use and when not to use. So why steroids are dangerous in one herpes patient while it's vision saving in another patient? Because this same diagnosis has a different disease pattern and different pathophysiology. So first, let's understand its concept and pathophysiology in depth. Then we can understand when to use steroid and when not to use steroid in case of herpes simplex. So this is the epithelial cells, this is the stroma, and this is the endothelial cells. These epithelial cells are virus infected, and this is our immune cell. Herpes virus infects mainly epithelium. And when this epithelium get infected, our immune cells come and it destroyed this epithelial cells which are loaded with virus. And we know that epithelium is mainly regenerative. So when this cell gets destroyed, another epithelial cell layer will come from here and will start regenerating. Okay, so epithelium will regenerate. So we want this immune cell to destroy our epithelial cells which are loaded with virus. So this is the preferred response. But sometimes this immune cells mistakenly destroys our stroma and endothelium. So why it is not favorable? Because we know that stromal fibers are non-regenerative. Okay, so it does not regenerate after damage. When the stromal fibers get destroyed here, it creates an opaque layer or opacity in that area. Okay, so it is not favorable. And when endothelial cell layer get destroyed, if these cells are get destroyed, it causes pump mechanism failure and increase in IOP. So this stromal and endothelial cell damage is not favorable by us. So we don't want immune cell destroy stromal or endothelial cells. So how to stop this immune cell? By the use of steroid drops. Okay, so steroid will inhibit this immune cell. Okay, so this immune cell will not damage further the stroma and endothelium. But we don't want this steroid to be used in case of epithelial disease. Okay, we want immune cell to destroy epithelial cells which are loaded with viruses. So we can understand that in epithelial cell disease, in epithelial herpes simplex keratitis, we don't want steroid, but in stromal or endothelium, we want to use steroid to suppress the immune cell. Okay, the concept is clear. Now let's understand it one by one. So as we understood that in epithelial herpes simplex keratitis, the virus is actively replicated inside the epithelium. So when we add the steroid drop, the local immunity gets suppressed. So now virus is spreading unchecked. And first of all, it was like this dendrite. And now the virus get unchecked and it forms the geographic ulcer. Whole epithelium cell whole epithelial layer gets involved and it causes geographic ulcer, and it has a corneal melt risk. So how to identify epithelial cell HSK? So it has a terminal bulbs stained by fluorescein stain, and if there is a no fluorescein, reassess, because we don't want to start steroid in case of a herpes simplex epithelial keratitis. Okay, now in stromal and disciform, why it is actually helping, that we understood that in stromal keratitis there is a no epithelial staining and only corneal haze or opacity, because as we understood that if the immune cell is attacking stromal fibers, then it will create a opacity there. So this opacity we can see here. So we want immune cell to get suppressed here. Antigen buried in a stroma triggers T cell and complement attack, and the virus isn't a problem anymore here. It's an immune system. So we want steroid to reduce scarring and preserve clarity. While in case of disciform or endothelitis, disc-shaped edema occurs and KP is on endothelium and increase in IOP. So endothelial pump is getting damaged by immune attack and fluid accumulate in stroma, and steroid restores this pump and vision clears within 1 to 2 weeks. So steroid resolves edema and restores the vision. So we want steroid in case of disciform keratitis or endothelitis. So understood that? So whenever you see this stromal keratitis or stromal edema with raised IOP, steroid is indicated, but under the antiviral cover. So the concept, as we understood, is if the virus is replicating, active viral replication is destroying epithelium. So steroid here feeds the virus and increase this virus spread. So then that become geographic. So no steroid here. While in immune response, in case of the stromal or endothelitis, we are treating the problem. So steroid under antiviral cover is recommended. How to approach this clinically? So whenever you suspect herpes simplex keratitis, first stain, okay, and if the staining is there present, then it is epithelial herpes simplex keratitis, so topical antiviral and no steroids. But if it is not getting stain, then it's a stromal or disciform keratitis, so first oral antiviral plus topical and then steroid addition. Okay, and in all cases check IOP, take history and monitor every 2 weeks. So we'll map it by layer, so it becomes simpler. In case of epithelial herpes simplex keratitis, whether it's a dendritic or geographic, virus is dominant, so will not give any steroid. While in case of a stromal keratitis, necrotizing or immune stromal keratitis, immune response is dominant, so will give under the cover of will give will give under the cover of antiviral. And in endothelitis, disciform keratitis or endothelitis, inflammation is predominant, so will give under the cover of antiviral. So think by layer. Is epithelium, stromal or endothelial layer is getting involved. So last quiz, would you start steroid in this case? 32 years old female, third episode in left eye of redness plus photophobia and vision is 6 by 18 for 5 days. No fluorescent staining and central disc shaped stromal edema is there. KP is on endothelium, IOP 22, mmHg, and no current medication going on. So, would you start steroid here? And if yes, what else and why? Give your answer in the comments. So, we have to treat the mechanism, not just the diagnosis. Understand the pathophysiology, so the management part becomes very easy.